now move over to a close friend of mine, Dr. Sanjaya Vishwamitra. He's a radiologist. He's a professor and head of the Department of Radiology at the Sri Sathya Sai Institute of Higher Medical Sciences. He's also the past president and current executive member of the Indian Association of Cardiac Imaging. He's extremely proficient in both cardiac and general radiology, a teacher par excellence. He has multiple research publications and numerous research projects. He'll be talking about the role of CTA, that is cardiac CT in heart failure, coronary evaluation, volumetry, and lots more. Over to you, Sanjay.
Good morning. Thank you again for the invitation. Are you able to see my screen?
Not yet, Sanjay. 1 second.
Let me see where I can. So thank you again for the invitation from Dr. Mahapatra and the group. Thank you for Dr. Joanne Christopher for a wonderful introduction. My topic today is going to be to discuss CTA findings in heart failure. And I thank my team with Dr. Faisal, who helped me prepare the presentation, and all my other team members that you see here for contributing to the understanding that we have about heart failure in general. So prior to my talk, I was trying to understand exactly where CTA fits into the paradigm. And one of the CSI position statement papers from 2018 published in the Indian Heart Journal, basically, which includes many of the speakers in this group as well, including Dr. Joanne Christopher, discussed heart failure in comparison to how it affects the Indian population as compared to the Western population. And a couple of comments they made, of course, which is familiar to the entire group, is that it occurs earlier, there is a male preponderance, coronary artery disease is the most common etiology, followed by idiopathic dilated cardiomyopathy. Valvular disease can still contribute to heart failure as well. So these are some of the comments that were made. And I looked at this article in more great detail, hoping that it will share some insight into where the guidelines state CTA needs to be used. And they basically talk about coronary artery arteriography as an invasive procedure. And essentially what they state is that the invasive coronary angiogram is a recommended procedure simply because of the high prevalence of CAD in the young population in India. It is better to err on the side of doing a coronary artery angiogram rather than not doing it. So that's the position statement that they have. Which brings me to what cardiac CT can contribute. And I felt I'm in a bit of between a rock and a hard place, because you clearly have echocardiography and MRI, which does a fantastic job in evaluating the heart. On the other side, you have PET imaging as well. So I must have done something inadvertently to get Dr. Satish Govind, Prabhu, and Joanne Christopher to give me this particular topic and put me in a bit of a rock and a hard place. But I'm going to try to do the best I can. So cardiac CT, essentially, we know evaluates for coronary artery disease. And as I showed you in the CSI paper, that is something which is critical. We can also look at how cardiac anatomy, the cardiac function size, and extracardiac findings can all be evaluated with cardiac CT. This is a common slide which people have used in the past, in the sense that calcium score has made its critical role in the evaluation for coronary artery disease, and also as an independent prognosticator. We know that as the Agatston score increases, there is an increase in the prevalence of major adverse cardiac events as well. So this is something which we know quite well. But where does it fit into into congestive cardiac failure? Where does it fit into the heart failure group? And this interesting article here from Nakanishi et al. Published very recently in 2022, explored the association of coronary artery calcium score on non-contrast chest computed tomography as an independent factor, or basically as a risk factor in all-cause mortality with congestive heart failure. And what they found very interestingly is if the calcium score is over 1,000, there is an increased hazard ratio of 1.5 in these patients with CHF. If you further take these patients who have had invasive angiography with stenosis of greater than 50% and use the same 1,000 calcium score, then the hazard ratio increases to 3.668. You can also look at the ejection fraction in the same patients, and then you also see that it has an increased risk factor, HR of 2.1. So calcium score can independently predict and perhaps even stratify the presence of poor prognosis as an all-cause mortality within this group of patients with heart failure. Valve disease is something that has been discussed multiple times as one of the things that one needs to look for in patients with heart failure. We do see valve calcification frequently on coronary artery calcium scores and even on our CTA. And this essentially this paper from 2021 looked at basically the severity of aortic valve disease in relatively asymptomatic patients who were perhaps going for an indication of surgical valve disease. And they compared the presence of severity simply based upon the presence of calcium within the valve. And they actually showed that a calcium score of greater than 1,200 in women and 2,000 in men has an adverse predictor, or basically indicated that there was a greater severity of aortic stenosis. Two other articles which I will share very briefly. This was retrospective cohort study, again looking at over 10,000 patients from the CAC consortium, and they looked at 8-year follow-up. They also looked at Agatston scores measured at the calcification of the aortic valve leaflets, excluding any annular or root calcification. And they basically underpined the importance that aortic calcification, just like calcium score in the coronary arteries as well, as a subclinical atherosclerotic marker. It indicates the presence of atherosclerosis. And in these patients too, it has a high risk of aortic stenosis and all-cause mortalities. This is just another article basically looking again at usefulness of routine aortic valve calcium, and routine being in patients who just have routine calcium, who have routine MC multi-slice computer tomography. And they basically again looked at calcium scores of close to what I've shown you earlier, around 1,000 and 1,000 plus, as indicating severity of the presence of aortic stenosis. So calcium score can also be used for aortic valve disease. What about coronary artery disease itself? And in terms of left ventricular ejection fraction, where does CTA play a role in these two entities? I don't need to introduce CTA to the group. I'm sure all of you are very familiar with the fact that coronary artery CTA can evaluate the coronary arteries extremely well. This is just a meta-analysis recently published again in 2022, discussing the diagnostic accuracy of coronary artery CT angiography in evaluating of ischemic workup, again in presence of heart failure. The main question here was heart failure. And they basically again came to the conclusion that CCTA has an excellent diagnostic accuracy in diagnosing the presence of significant coronary artery disease in newly diagnosed patients with heart failure with reduced ejection fraction. So perhaps instead of going for the invasive angiography, one can start off by doing a computer tomography CT angiography instead. All of you do not need to be again shown images such as this, where you can see the coronary angiogram, the origins of the coronary arteries, the presence of any stenosis in smaller vessels as well, presence of any aberrant vascular origin, such as this particular right coronary artery, which is coming off between the roots of the aortic valve and the pulmonary valve. And also you can evaluate the presence of the endocardial border to use Simpson's or modified Simpson's rule to look for ejection fraction on a coronary artery CTA, if it's done in the retrospective mode for ejection fraction, otherwise prospective mode for anything else. So looking at an article from Abdul Rahman's clinical uses to emerging technologies published in 2020, this basically was a nice summary of where we stand. We look at coronary artery calcium, we look to evaluate the coronary artery disease, and we can categorize the significance of stenosis between no coronary artery stenosis to greater than 70% and varying degrees in between. So we can do this quite easily. We can also look at calcium itself and look for the presence of any high-risk plaques, such as low attenuation plaques. We can look for positive remodeling. We can look for the napkin ring sign, and we can basically look to see whether there is some additional information that coronary artery disease coronary artery CTA can give you with plaque analysis. The possibility of epicardial fat quantification and epicardial fat attenuations can also be used to predict the presence of future events. So we know all of this now. If you're looking specifically for patients who have acute ischemic changes, then the presence of a fractional flow reserve can also be used to identify the coronary artery, which has got a more significant area of stenosis and the significance of the stenosis itself. This is something which I'm sure all of you have also come across. We have come across cases with AV shunting, AV malformations. This is just an example of a large area of an AV shunting in the region of the renal vein. This is from an article of the emerging role of cardiac CTA in heart failure, again 2019, showing you an aberrant right coronary artery as well. So these are some of the common etiologies as well. Can LV function be performed with cardiac CTA? We know that echocardiography and CMR are going to be the gold standards and that we would really like to use that. But this article, which basically from an older article from 2012, essentially said that as long as you have a relatively good CT scan at 64 slice and above, then you can basically use LVEF calculations. It's a little bit of a staccato type of appearance. As you can see, it's not a very smooth appearance, but you can certainly look to evaluate for function. Now, interestingly enough, this is an article recently published, again, January 2022, which has started to look at strain analysis. And all of you have just heard some wonderful lectures in the last 2 hours where strain analysis is an important feature, important requirement for evaluating for for heart failure. I'm just going to put these images out in front of you. I don't claim to be an expert in strain analysis, so I will let the cardiologists in the group assess the image quality for themselves. And this is, thank you. This is in comparison to speckle tracking and 4D CT. They looked at the right ventricle and they also looked at left atrium as well. And we know how important left atrium is. So should we give left atrial volumes? It's a relatively easy method of evaluating. This is actually a deep learning method which looked at good dice scores in terms of basically being able to evaluate the presence of left atrial volumes. Certainly, we know that left atrial morphology can also be characterized in patients who go for therapy planning. These are just some 2 random cases that one might come across, and I would not recommend using cardiac CT, but you might come across things like non-compaction and fat involving the wall as well in cardiomyopathies. So what is known? We know that patients with cardiac CT, with heart failure present often with obstructive pulmonary disease, and we know that classification influences mortality. So what about emphysema? If you look at extracardiac findings, we can see that the presence of the central lobular emphysema as shown by these lucent areas within the lung can be visually seen as on cardiac CT. We can also use quantitative methods to identify the degree of quantification that we have within this particular emphysema. So you can actually look to see for quantification of obstructive disease. I'm going to go relatively quickly through these slides so I can get through my presentation. We obviously know that left heart failure is something that we see frequently on cardiac CT. This is the classic paradigm of what happens in pulmonary edema. And this is what you see. You can see basically bilateral pleural effusions, the prominent secondary pulmonary lobular structures, which are classic for heart failure. And this is just two other examples of showing CT evidence of heart failure. You can also look for right heart strain in terms of flattening of the right ventricle, the paradoxical interventricular septal thickening, the reflux within in the hepatic veins, and presence of pulmonary embolus if this patient happens to have any as well. I'm going to add this interesting concept here because we also know that COVID-19 has increased the cardiovascular risk. And I know that primarily we are looking at myocarditis and long-term COVID abnormalities, but that COVID-19 is also increased in risk of lung disease as well. And you can see that severity of COVID-19 cases are shown in these 2 images that I'm showing on the right, where you have milder disease along the periphery and you have more severe disease along the entire lungs bilaterally on the lower set of images. And this is just an example from one of the patients that we saw where you can basically see this patient came in with bilateral lung disease and had to be put on an ECMO. You can see the ECMO catheter in about a period of 17 days where he became much worse. And we also see patients with COVID-19 having LVAD as well because they progress onto heart failure as well. So perhaps there is an interesting role for looking for COVID-19 disease and heart failure as well. We are now in the area of precision medicine. And this article from Stephen Achenbach, which basically also includes several of the authors or the speakers in this particular meeting, discusses the importance of phenotyping to determine the etiology of heart failure, epicardial coronary artery disease, acquired valve disease and pericardial disease are the three things which we can perhaps come to. I've already discussed that strain analysis is something that seems to be a new kid on the block as far as CT is concerned. So in summary, what I would like to say is that MD-CT can be achieved at a relatively short examination time. Echo and CMR continue to be the main modalities, but when CTA is performed, we need to start looking for additional information. A calcium score or an aortic score greater than 1,000 is something that we need to add to our reports. Coronary and cardiac anatomy assessment, LV ejection fraction, we can add atrial volumes as well. And we should certainly look at extra cardiac applications as well. And with this, I thank you again for your attention. And once again, thank the organizers for giving me this opportunity to speak to all of you.
Thank you, Dr. Sanjaya, for this enlightening, thought-provoking lecture on CTA.